To improve models of care for people with complex needs. I'm Georgia Maharis, Project Director for the Vermont Healthcare Innovation Project. I'll be moderating this afternoon's webinar. This is the third event of the Vermont Healthcare Innovation Project's webinar series, which presents a webinar on a new topic monthly on the second Wednesday. Before we get started, I'd like to go over a few items so you know how to participate in today's event. On the left side of this slide, we've included a screenshot of the webinar's attendee interface, the control panel. You should see something that looks like this on your own computer desktop in the upper right-hand corner. You're listening in with your computer's speaker system by default. If you would prefer to join over the phone, just select telephone in the audio pane and the dial-in information will be displayed. We have a couple of housekeeping items. We've set aside time for discussion and questions at the end of this webinar. You will have the opportunity to submit text questions to today's presenter by typing your questions into the questions pane of the control panel. You may send in your questions at any time during the presentation. During the Q&A session, we will have a moderated discussion to answer your questions. Today's event is being recorded. The slides and recording will be posted to the VHCIP website, healthcareinnovation.vermont.gov, within the next few days. You'll be notified when these materials are available. At the end of today's event, you'll be redirected to an evaluation survey. Please complete this survey. We value your feedback. Finally, I want to thank Chrissy Geiler and Sarah Kinsler for planning this webinar and taking charge of logistics for today. Our presenter today is Caitlin Thomas-Henkel. Caitlin is a Senior Program Officer at the Center for Healthcare Strategies, CHCS. In this role, she primarily works on CHCS's initiatives to integrate care for Medicaid beneficiaries with complex needs and assists with technical assistance efforts related to the Center for Medicaid and Medicare Innovation State Innovation Model Program. Caitlin also provides targeted technical assistance focusing on integrated care to states under the Robert Wood Johnson Foundation Aligning Forces for Quality initiative. Before joining CHCS, Caitlin served as the Deputy Director of Policy for the Rhode Island Senate President, staffing the Health and Human Services Committee and all legislative matters. Prior to her work at the Rhode Island Senate, Caitlin served as the Director of the Mayor's Substance Abuse Prevention Council in Providence, Rhode Island. She also worked as a coordinator in substance abuse prevention in Massachusetts and as a therapeutic support professional at an alternative educational collaborative for youth diagnosed with complex neurological and behavioral disorders. She has a bachelor's degree in family studies, child development from the University of New Hampshire and a master's in social work with specialties in clinical and macro practice from Boston University. Welcome, Caitlin, and thank you for joining us today. We're going to start today's discussion with a quick overview of some of the care transformation activities currently underway in Vermont, focusing on those supported by our State Innovation Models testing grant. The main presentation will follow, and we'll end the hour with some time for Q&A. CHCS supports a variety of transformation activities. I think you've all should be familiar with many of them, and just want to highlight a few of them for you. In particular, our Integrated Communities Care Management Learning Collaborative, our core competency trainings, our Unified Community Collaboratives, also known as Regional Clinical Performance Committees, the efforts within our Blueprint for Health, and our subgrant program. Starting with the Learning Collaborative, we have a focus here of cross-organization care management looking at risk populations. We have 11 communities participating, including about 200 providers. This particular collaborative focuses on a Plan, Do, Study, Act quality improvement model, and is a combination of in-person learning sessions, webinars, implementation support, and key interventions. And for those of you who are involved in this, know that we are working on developing some toolkits and other guides to sustain this particular program. Moving on to our next area of focus is our core competency training. As part of our learning collaborative, we realized that everyone wanted to have the benefit of some deeper dives into a couple of core areas of training. So we're doing some comprehensive training for frontline staff providing care coordination and also focusing on disability awareness. There will be a series of multi-day in-person trainings that impact frontline staff, supervisors, and importantly, a train-the-trainer model so we can keep the momentum around this training moving past 2016, with the hopes of having up to 240 participants involved. Those are just kicking off this month. Next up, we have our Unified Community Collaboratives, known as Regional Clinical Performance Committees, and they go by many other names in various health service areas. They're operational in each of our health service areas and build on the foundations created by our Blueprint for Health community health teams, layering on ACO participants, community providers, and anyone involved in care coordination and care management within each community. Next up, our Blueprint for Health, which of course promotes the patient-centered medical home through primary care across the state, leveraging our community health teams in each region of the state. We have over 700 practices participating and over 300,000 attributed patients in this program. We also have our subgrant program, and our subgrant program has several different smaller projects impacting hundreds of thousands of Vermonters all across the state. Starting with our Rutland program, it's a supportive care pilot program, and this is really looking at how can we make sure that we're transitioning care and providing an appropriate level of support for those who are interacting with our hospice and palliative care programs in the Rutland region. Next, in northeastern Vermont, the St. Johnsbury area, we have a dual eligible project where we're focusing on flexible funding and providing resources for those who are dually eligible for Medicaid and Medicare. Next up is a project that White River Family Practice is involved in, a collaboration with the Dartmouth-Hitchcock School of Medicine and Dartmouth-Hitchcock Medical Center. And this is really looking at how we can improve patient confidence to have a better care delivery model and reduce readmissions and inappropriate admissions to a hospital. In southwestern Vermont, there's a transitional care model that's using specific types of nurses and nurse practitioners to provide support as individuals transfer from one physical setting to another physical setting across the continuum of care. We then have the Inclusive Healthcare Partnership Project that's run by the Developmental Disabilities Council and Green Mountain Self-Advocates that's really looking at how can we get a better level of disability awareness and care for those with disabilities in Vermont. In addition to these specific SIM-supported activities, I want to be very clear that there are many, many other programs underway in Vermont that focus on care management, quality improvements in this area, including Medicaid's Vermont Chronic Care Initiative, initiatives by Blue Cross Blue Shield and MVP, the Support and Services at Home program. There are too many for me to possibly list, but just want to acknowledge that those are also out there and that folks are really working together within each community to coordinate these efforts. With that, I think I'm going to turn it over to Caitlin.
Great. Thanks so much, Georgia. If you could advance to the next slide, please. As Georgia mentioned just briefly, for those of you that aren't familiar with CHCS, CHCS is a nonprofit health policy resource center that is dedicated to advancing quality, access, and affordability of publicly financed care for all Americans. We're located in Princeton, New Jersey, and we work across 3 core principles, priority areas, healthcare access and coverage, delivery system and payment reform, and integrated services for people with complex needs. And I will be focusing on primarily on the third bucket, the integrating services for people with complex needs. Next slide, please. So a little bit about this project. This project was a year-long initiative that was funded by the Robert Wood Johnson Foundation. And it included a focus on a small percentage of patients that many of you are very familiar with, whether uninsured, Medicaid, Medicare, or commercially insured, that use a disproportionate share of healthcare services as well as other services within the system. And estimates account around 50% of healthcare costs. These folks often face multiple physical, behavioral health, and social challenges which contribute to their largely ineffective and costly interactions with the system. I won't just focus on healthcare there. So through this year-long initiative, we had 2 primary goals. The first was to identify those effective strategies for improving health outcomes and lowering costs for, as I'm going to use the term, high-need, high-cost populations, and second, to explore critical gaps that must be addressed to better integrate their health, social services, and produce desired outcomes, the triple aim. We had a few key project activities that we undertook, including a literature review of gray and published material, an environmental scan consisting of interviews with 22 experts representing health plans, providers, including behavioral health folks, some consumer advocates, among others, and researchers. We held a day-and-a-half-long small group consultation to gain feedback and insights from folks on what the recommendations, findings, and emerging topics in the field. And finally, we disseminated our key findings across 6 domains. So this slide before you shows the 6 domains of how we organize the content, and I'll be using that today to talk through some of the recommendations and focus primarily on those key opportunities for further exploration, which is based largely from our interviews, conversations with folks in the field, as well as research of what's percolating across the country with innovation with high-need, high-cost populations. Next slide. So, care model enhancements. When we use this term, this refers to clinical interventions that are being employed for people with complex needs. As you are aware, these patients have really complicated needs, and they often require tailored approaches to engagement, conducting needs assessments, and care plan development and coordination. One of the first emerging themes was really teasing out the effectiveness of specific interventions. Programs employ a variety of interventions, but often there is insufficient understanding in what's really working and what's most effective for population subsets that fall under the umbrella of high-need, high-cost populations. There's opportunities at both the organizational level and broadly to try to identify and isolate those key drivers of impact and tailor interventions accordingly for the subsets. The next, dosing, and this does not have to deal with pharmaceutical dosing. This has to deal with the substantial variation across programs with clinical intervention. And we found a few themes. First, the frequency, as an example, the frequency of contact often between care teams and high-cost patients varies, as well as the duration of engagement in ongoing care management activities. Finding opportunities and really digging into effective scaling and sustainability will require much more understanding of exactly how much of the intervention is needed and for how long, given the implications and costs for implementing these models. And finally, I'll give an example here. Through our research and our interviews, there was a lot of advocacy for strengthening those connections. Since high-need, high-cost populations touch multiple systems, even outside of healthcare, really ensuring that there's connectivity across systems for both information exchange and care planning is critical. Maimonides Medical Center in New York, through its Brooklyn Health Home, they use a web-based dashboard and text messaging alerts to encourage collaboration across hospitals, outpatient providers, care manager, and other community-based partners in both housing, criminal justice, and other venues. Next slide, please. Workforce. Through our findings and recommendations, there was really a call to try to standardize tools and training for people with complex needs. Developing specific training curriculums was something that many of the experts felt was necessary in the field. There were a few topics that were pulled out that include focusing on substance use disorder treatment, pain management, team-based care models, motivational interviewing, and soft skills in terms of empathy, engaging with clients. Also, trauma-informed care was something that many folks talked about, and really what that means and how to train folks before they enter the field. This training could occur both within medical school or as a part of residency requirements. In addition, workforce is a very hot topic right now, and we definitely heard that loud and clear through our work. Many programs that successfully implement complex care management and achieve outcomes use models of accompaniment where they're using non-traditional health workers, peers, and navigators in innovative ways. Paramedics are being deployed through pilot programs to focus on high-need, high-cost populations. As one example, Commonwealth Care Alliance, which is in Massachusetts, is currently piloting a community paramedicine initiative. They're deploying specially trained paramedics through a waiver from the Commonwealth to individuals' homes to avoid unnecessary admissions. The paramedics are doing things such as conducting basic investigations, labs, vital signs. They're taking specimens for follow-up, and they're initiating treatment plans. They're giving IV fluids, antibiotics, and wound care. And CCA has been able to connect those folks with other resources and supports within their system to avoid unnecessary hospitalizations. And they've achieved some great outcomes, as well as patients have been very satisfied with the care that they're receiving. And the other piece that I'll highlight is a program known as Medical Legal Partnership, which is located across the country in pockets. Medical Legal Partnership uses lawyers as part of the care team to assist with those social challenges, specifically legal challenges, evictions, obtaining and maintaining access to disability benefits, and providing other critical supports. This intervention is prefaced on the idea that a high proportion of low and moderate income families face significant legal challenges that really influence their overall health. And finally, there was a call to develop more unified crisis systems within states. For folks with complex needs, they frequent both health and non-health systems. Creating more unity across the system to address the medical and unmet social needs is a definite must. As an example, Mercy Maricopa in Arizona, they've developed formal connections with law enforcement, corrections, child welfare, housing, and shelter services. This is allowing them to more efficiently identify, engage, and meet the needs of individuals who frequently bounce between those systems. Financing and accountability. Obviously, Vermont is very progressive with their financing, but I'll talk about a few examples that we called from our findings. So the first is really focusing on risk adjustment methods to account for the social complexity of these patients. As an example, New York Health Homes has recently modified their payment structure to include an assessment for patients on a monthly basis to indicate whether they would be billed as high, medium, or low rates. And I'll talk about a few of the criteria that they use. Having a serious behavioral health need, baseline acuity, HIV positive, homelessness, incarceration, inpatient stays for mental illness, inpatient stays for substance use disorder treatment, and active substance use and/or functional impairment. The patients are given a rate with a PMPM that ranges depending on where they are. This rate structure allows the PMPM rates to fluctuate, and it can accurately reflect the complex and dynamic nature of coordinating care for this complex population. Next, braided or blended funding streams is a very hot topic, and there's many examples of this across the country. Many counties are well suited to capitalize on these approaches, given the role in funding across the array of both health and social services. And there's opportunities to align accountabilities across systems. As one example, the Center for Healthcare Services in San Antonio, Texas, they actively track their impact on an array of criminal justice outcomes, which has increased its financial support from county-based law enforcement and correctional partners. Finally, there's many opportunities that emerged, and I'll highlight one state, but states are really using their Medicaid managed care rate setting as a opportunity to address folks with complex needs. Currently, there are two opportunities to refine approaches, including, over the long run, the savings generated through more effective models of care reduce rates paid to MCOs when the rates are reset in future periods. Addressing that piece is critical, as well as MCO investments in non-healthcare services such as housing are often not taken into account in rate setting, which generally reflects only the cost of Medicaid covered services. We're seeing some innovation here, as I mentioned, across the country. I'll talk about Pennsylvania. They're one of the states that has recently taken some of their managed care contracting for high need, high cost. And what they're doing is they're supporting community-based care management for high volume, high risk patients to better integrate physical and behavioral health. The state has allocated funding for this initiative, and the financing model they're using is a fixed fund based on a PMPM basis that's divided across the plans through a monthly cap. They're very focused on preventable admissions, readmissions, and using community care teams across providers. Their payment includes care management, transitions of care, transportation, and medication management. Data and analytics. As many of you are very aware, complex patients are quite a heterogeneous group. Leading providers emphasize the importance of identifying subgroups. The segmentation can look very different depending on providers. For instance, Camden Coalition of Healthcare Providers often focuses on ED visits versus frequent hospital admissions, or by patient characteristics. As one example, Spectrum Health Center for Integrative Medicine in Western Michigan defines their high-cost users at their clinic by 7 subtypes. Spectrum identifies those patients as those that have 10 or more ED visits in 2 of the last 3 years. They also use inpatient admissions in their criteria. Among the 7 subtypes includes the pre-complex patient. This is often described as the patient, the mother who is opiate addicted, and among the characteristics for this subpopulation include higher rates of prematurity, prolonged stays in the NICU, poorly controlled addiction, and poor screening of behavioral health in obstetrical care. Spectrum uses their interventions in a short-term period to tailor them to the specific subpopulations, in this instance to the mom, to ensure that she's receiving appropriate services such as substance use treatment. In addition, there's a lot of emerging conversation now in the field around the emerging populations, the pre-diabetics, the pre-hypertensive, folks that may not have yet, so to speak, hit the peak of meeting high need, high cost, but looking at indicators. There's many folks in the field, innovators like Jeff Brenner, that are talking about the need to focus on this population and figure out ways to identify them more early on before they hit that peak. And although there's no substantial evidence base at this point, it's definitely something that's being discussed. And I'll just give an example. There's a lot of interest in using proxy measures in addition to looking at admissions and other hospital indicators. Measures such as missed appointments and other indicators in addition to look at these patients and identify them before they hit that cusp. Moving on, increasing access to real-time integrated data is something that folks are very interested in. This allows a few things. One, timely targeting of patients for interventions, building comprehensive clinical care plans, and 3, supporting real-time tracking of ADT feeds and demonstrating those outcomes both within the healthcare system and outside. As an example, Washington Department of Social and Health Services has a PRISM system that you may be familiar with. This uses clinical support management as well as policymaking and program design. They use a combination of both predictive analytics, claims data, and other assessment across the system to drive their analytics. The web-based interface really allows providers a near real-time view of critical information to support efficient care. Finally, refining approaches to quality management. Standardized approaches to quality measurement for patients with complex needs would drive increased collaboration across providers and could also increase the pace at which effective models are spread. These measures would enhance efforts to employ more value-based purchasing agreements and drive better care for complex patients. As one example, Minnesota is currently convening a work group that's focused on identifying social determinants of health for potential inclusion with their quality measures. Michigan is also working on this in their new Medicaid MCO contracts. As a requirement, they're requiring the MCOs to report social factors and how the social determinant data will be collected and analyzed. So we're seeing a lot of innovation in terms of broadening and refining those approaches to quality measurement. Governance and operations. This is an area where there's a lot of folks talking about what is the governance model to support these approaches in states. And as an example, Hennepin Health and Maimonides Medical Center in New York, they have established strong partnerships outside of healthcare to develop reinvestment plans where their savings are generated through coordinated care management and allocated to community development efforts. The funds may go towards things like affordable housing, vocational training, and they're expected to increase the likelihood that healthcare savings will be generated. Governance boards play an important role in this in terms of prioritizing community development needs, identifying partners to implement those reinvestment plans, and bringing non-healthcare savings to the table to increase the overall reinvestment pool. Having the management capacity to support operational excellence is another key recommendation. Health Quality Partners, a nonprofit that's dedicated to research and development, attributes a lot of their success with high-need, high-cost patients to their efforts to reduce the variation in how care is delivered across the organization. They've developed a rigorous design, including evidence-based interventions to match to the target population and deploying appropriate resources that are measured through rigorous evaluation, participant feedback, and staff observations. The final domain, policy and advocacy. So I'll talk about this in my last slide, but there's a lot of emphasis on understanding what works and supporting replication and spread. As an example, Pacific Business Group on Health is partnering with physician groups in states across the country such as California, Arizona, Oregon, and Washington to spread their intensive outpatient care program for high-need, high-cost patients. This model was built on a few successful pilots that you may be familiar with, Boeing, PG&E, and CalPERS, that include self-insured plans and is now spread to Medi-Cal and the dually eligible populations. They target chronic conditions where hospital use can be prevented through intensive care coordination and self-management and the provision of ambulatory care. They've achieved early success with decreasing PMPM savings, hospital and inpatient reductions, and they've had very high patient satisfaction. PBGH has partnered with the California Quality Health Collaborative to develop a toolkit. And this toolkit is available online, and it's really intended to disseminate their best practices and share what's working to inform professionals in the field for their tweaks and program adjustments. Next, a lot of emphasis, as I've talked throughout the presentation, around the social determinants of health, with recognition that unmet social needs contribute as much as 40% to overall health outcomes. It's essential that we address these social factors. Simplifying access to benefits, including Medicaid, food stamps, TANF, and others, is a critical need for high-need, high-cost patients. As an example, Montefiore Medical Center reassesses their complex patients, integrating social risk factors, such as eviction notices, into their HIE, and care plans to trigger for increasing stepping up interventions and aligning agencies to help better support these patients. And finally, the voice of consumers. This is a definite important one in terms of understanding patient satisfaction and knowing if the interventions that we're working on are supporting and really working to meet that third factor of the triple aim. As an example, the Camden Coalition of Healthcare Providers, they work really closely with community groups across Camden and faith-based initiatives to engage their partners in activities such as care model development, the replication, and advocacy for state-level policy change. So what's next? So as I mentioned earlier, this is, as we view it, our phase 1 work with the Robert Wood Johnson Foundation. We're currently in the midst of launching a phase 2 known as Transforming Complex Care. Transforming Complex Care is an invited, targeted solicitation that's 2 years of funding by the Robert Wood Johnson Foundation. And this demonstration program aims to do 2 things. First, to standardize the core elements of effective care for high-need, high-cost populations. And second, to expand the universe through replication and understanding and teasing out what works. Currently, I'll go over a few things that this project will include. So 2 years of funding, we'll be funding up to 6 sites. And it will include a robust learning collaborative where we'll engage some of the premier subject matter experts in the field. We will provide extensive technical assistance to participating sites. And we will really promote a peer-to-peer learning exchange where providers will talk to one another and learn from one another and really understand and tease out that appropriate dosing and some of the recommendations that I gave throughout the presentation today, with a goal of accelerating problem solving across sites. And we really plan to have a robust dissemination strategy where others, if they aren't participating in this, they will still learn and have an opportunity to understand what's working and really spread the knowledge and expertise across the country. So if you'd like some more information, including access to the reports that I referenced, please go to our website, chcs.org. You can download those reports, including the literature review, the report that I referenced. You can subscribe to our email, our blogs, and you can learn about other efforts that are underway at our organization.
Thank you so much, Caitlin. We really appreciate it. We have a few questions that have popped up. As a reminder to all our participants, you can submit questions by typing into the questions pane of your webinar control panel. I'm going to facilitate our Q&A session. And so the first question we have is, if you could just talk a little bit about how long these changes take. You've given examples from several different organizations around the country, and we provided some examples of the progress in Vermont. And it'd be great to get a sense of, is this something that folks are going to be working on for the next 12 months, 12 years, any sense of timing?
Sure, that's a great question. We highlighted some innovators that have been at this work for a very long time, over 10 years, 15 years. I would say based on some of what we've seen for those folks that are doing innovative work, it takes a while. And when I say that, it's not a year, it's not 2 years, it's sometimes not 5 years. And often they are building off of foundations. In many states like Vermont, they have PCMH, where they are starting with PCMH, and then they are adding additional components. Some states are adding health homes. Other states are adding other interventions. So I would say that generally it is a progression, and it is a continuum in terms of implementing and tweaking along the way. That was clear in many of our conversations with the experts and folks on the ground, is that their programs are not stagnant. They're constantly changing and evolving and figuring out things that are not working and really making those mid-course adjustments with the dosing of interventions, with what's working, with the evidence base to achieve better results and outcomes. Thank you.
We have a specific request around the New York Health Home Initiative. And you'd indicated that the providers do monthly patient assessments. And so we're just wondering if you could talk a little bit about how that rolled out in New York, or how that is rolling out in New York, if providers had any significant concerns about additional administrative burden, if providers feel that this assessment is of clinical value or not, and how that's been playing into the work that's happening in New York.
Sure, I can touch upon it a little bit. I don't specifically work on New York Health Homes, but I can talk to some of the knowledge that I have, and then I'd be happy to reach out to my colleagues if someone has additional follow-up questions. But my understanding with New York is that they undertook an extensive stakeholder engagement process, and they do that through their health homes, where they have, I believe it's quarterly meetings. And this is a new initiative, so this just rolled out within the last few months, is my understanding. But I believe that they did engage providers around the development of the assessment tool, and they incorporated much feedback. I would have to touch base in terms of the burden and just questions around managing that and tweaks with my colleagues, since it is a relatively new process. But my understanding is this wasn't something that the state just put forth. They engaged providers throughout the course of, I believe it was at least a year, in terms of gauging consensus and feedback in the development of the assessment tools.
Thank you. Yeah, I think we would appreciate any additional information on that and appreciate what you can give us in the future. And so for folks who are participating, we would get that additional information out to you once we have it. And if we have another question really about how to really get at identifying that high cost, high needs, those high cost, high population, high needs populations. You talked a little bit about how some different health systems around the country are identifying these individuals. If you could provide some of the emerging measures or the way that you can track. I know that there's a lot of data mining, and you touched on that, and your report touches on that. But if you could dive into that a little bit more, that would be great.
Sure. So this varies substantially depending on just what data is available. But overwhelmingly, there is definitely agreement that relying solely on claims data is insufficient for many reasons, one being the lag in time that it can often take to access claims data. In addition, it's often not telling of where a patient specifically is at in terms of their needs. So I would say generally there is a call among some of the innovators to really use a full array of data that's available. There's a lot of interest right now in looking at cross-system data. I mentioned Washington State as one example, but beyond just Medicaid claims, there's some work being done with data warehouses where, like Michigan, is looking across healthcare services. They're looking at child welfare for more upstream There's a lot of interest in that. Washington State's doing some work with kind of the pre high need, high cost populations. So, and there's other things, as I mentioned. Proxy measures are something that are being used. A lot of researchers have interest in that, in looking at things such as missed appointments and other indicators at the provider level to identify patients that may be at risk for substantial ED visits or inpatient admissions. So generally, I would say it should be a combination of data sources that should be used beyond looking just at readmissions and hospital stays. In addition, there's a lot of discussion around regression to the mean, and in terms of addressing that, a lot of providers are advocating that data be looked at, a look-back period of around 2 to 3 years, and setting a target like Corey Waller in Michigan uses 10 or more ED visits to really get a picture, because oftentimes folks will enter the system and have a period, as many are aware, of hospitalizations, and then they will just naturally drop off. Whereas if you establish a look-back period, that allows for more of a comprehensive picture to look more longitudinally at the patients and where they're falling in terms of over time versus one acute episode.
Thank you, Caitlin. Following up on that, could you talk about some of the exciting innovations? You've hit on a couple that are really developing in this field, and in particular looking at not just those that are the high needs population, but that category of folks who I would say are in the the pre-diagnosis or haven't quite hit those 10 visits over 2 years to an ED, and really getting ahead of the intensive services. So if you could talk a little bit about that, that would be great.
Sure. So this is definitely, as I mentioned before, this is an emerging item that other reports have talked about and many providers are discussing in terms of catching folks before they have those acute hospitalizations, and really beyond looking at the data, also looking at just behavior change in terms of where folks are at, so the pre-diabetics. And I would say some of the innovation that's being used is, one, as I touched on before, the various data sources that are being used. We're seeing a lot of providers on the ground incorporating social determinant data at their provider level to look at risk factors using algorithms. Now, when I say that, everyone gets a little, oh, an algorithm, it's a really intensive process to develop one. But many of the researchers in the field say simplify it. Keep it simple. We were recently at a meeting where a provider in FQHC talked about their algorithm, and they have 10 different indicators that they use, and among those include waiting for housing instability, behavioral health episodes, looking at substance use disorder, food insecurity. So I would say that that's something that is being used, and it's not often widely disseminated, but there's innovation happening across states where they're finding that these social factors really are detrimental, and really looking at how those can be combined with other inpatient and other utilization measures to look at those folks that are the, I will say, pre and emerging high need, high cost patients.
Thank you. Do you have any examples of states that are doing this kind of cutting edge social determinant work really, really well, or alternatively health systems that have started to crack the challenge of getting this information, as you indicated, don't make it too hard on yourselves, right, but really able to get it done quickly and effectively to support clinical care?
Sure. So I think this is definitely an emerging trend. I touched upon Minnesota's work, where they're convening a work group of state agency folks as well as social service providers to look at identifying social determinant measures to include as part of their quality measure set. So that work is underway. What I would say is that there's, we hear pockets of innovation where this is happening at the provider level or within states like Minnesota that's trying to, I would categorize it as more standardized, the assessment tools and process that they're using. But generally speaking, I would say this is a nascent part of the field, just in my opinion. Others could feel otherwise, where there's a lot to learn. And I think that, just as in the case of, as I talk about Camden and others, I think we're probably going to learn most from the providers who are on the ground, who are using these tools, who are using and beginning to, you know, innovate with their work. So Michigan is the other one that I would say that's attempting through their managed care rebids and their contracting process to kind of standardize and understand what's happening with providers by requiring providers to report on the social measures and what they're using. So those would be a few examples that I would highlight.
Thank you. Want to shift gears a little bit. You had some great examples in your presentation, you know, in particular around focusing on certain targeted populations. And I'm wondering if there are any states, any health systems, or any of your research has talked a bit about kids and kids services. In particular, you know, up here in Vermont, we have an innovative program called Integrated Family Services that focuses on all of the mental health services that a child needs and that their family needs, and really provides those links not just for kind of the pure psychologist, psychiatrist services, but bridges all the way into the educational system. So didn't know if there are any, you know, any other examples or any other things that really are targeted at children that you can identify.
Sure. So I will say up front as a caveat that our report primarily focused on adults, but we're definitely seeing where there is this movement in terms of, you know, also talking about what's percolating of upstream, in terms of working across systems and identifying children that are at risk potentially in the future for becoming high-need, high-cost utilizers. And Washington State is one that comes to mind. They're doing a lot with their PRISM data and their various data sources to look at indicators with children that are involved with the child welfare system as well as other systems, and identifying risk factors and different pieces that could put them at risk for emerging healthcare utilization. So that would be one example, and really trying to tailor those wraparound supports and services to those kids. I think a lot of that work is emerging, so I can't speak to you know, any results or outcomes, because it's definitely something that's evolving with the state. And the other example I would give, which you're probably all well aware of, but obviously through health homes, there's a lot of work underway with children with serious emotional disturbances, and a lot of states are learning through those focused initiatives of health homes what are the necessary supports and services for children with primarily behavioral health needs.
Thank you. Shifting gears again, just want to see if any states are really focusing on pharmacy or any pharmacy reforms. You know, that it's starting to be, I think, become more and more significant for states as they deal with just the cost growth side, in particular, that's hitting Medicaid programs. And CMS did announce some a new proposed rule for the Medicare population yesterday. And so wondering if there's any impact that you're seeing or that you've been able to identify in states in the pharmaceutical area.
Sure. So in terms of pharmacy, at the state level, I can't speak to specific states, but what I can say is at the provider level, polypharmacy is something that many of the sites are using as an indicator and weighting it heavily for identifying high-need, high-cost populations and tailoring interventions. So that's something that is definitely among the risk scoring. Polypharma is pretty much universally used as an indicator and something that they're finding which is important. And there are states that you're probably aware that include pharmacists on community care teams as a required care team member to help address those needs, since it's seen as such a critical element with with achieving outcomes for patients.
Thank you. I think just a couple more questions that we have time for. Want to just touch a little bit on workforce, because I think we've hit the other categories that that was the framework for your discussion and your report. And so really just want to talk about, are there, there's team-based care, which is quite evident in all of these models. Are there any professions or, types of workforce individual and skills that are really burgeoning and saying, hey, we didn't need this many of X in the past, and it's turning out to be really, really critical, like panel managers or something like that, that you can identify?
I would say in terms of how the field is evolving, there's definitely a lot with health professionals right now in terms of paramedics, and really in terms of how they can be utilized to work to the top of their skill set in innovative ways. And with that being said, it's something that's allowing the other professionals to work to the top of their license. So paramedics would be one that I would call out. In addition, I would say that community health workers are also being used in more innovative ways. And we've heard a lot of evidence about med techs as part of community teams, both at the clinic level, where they're actually doing different things such as helping with rounds and leading things that may not necessarily require additional licensure, but it really frees up the other professionals, the MDs, the nurses, to do other tasks. So that's definitely something that we're hearing and seeing in the field, is how can they help augment and complement the skills so that the other professionals can work to the top of their license.
Thank you. And then I think for our final question, I was wondering if you could just talk a little bit more about the Phase 2 learning opportunity, what CHCS is hoping to accomplish, and really, what, timing and sequencing. Thank you.
Sure, great question. So we're currently, in terms of timing, we are in the process of reviewing the all of the RFPs, and the targeted date for the launch of the initiative, where funding will be available to the 6 sites, is May 15th, so it's roughly 2 months away. And we will be conducting site visits with those different programs, and our intention really is to, there'll be, I should mention, there'll be a geographic diversity with this project, which we're really excited about. So we, received applications from all over the country without talking about specific areas, but we definitely have many different programs that potentially we will be funding, and we're excited about that opportunity, both from the geographic standpoint as well as the different ways that programs are delivering complex care to folks. So that's something that's really exciting to us, to see that emerging across the country. And I think the Learning Collaborative is something that will be really helpful for many of these sites, and some are very sophisticated in certain areas and more further along. They can learn from one another, and that peer-to-peer exchange, I think, is often most beneficial to providers, at least the feedback we receive. So our hope is that the Learning Collaborative will be an opportunity for them to really come together and learn from one another. And the overall goal of this really is, as I mentioned before, to replicate and understand what's working for other folks across the country. And we do plan on having a very robust communication strategy to share the findings from these sites with others that may not necessarily be involved in the initiative, but would benefit from learning.
Thank you. That sounds really, really exciting, and I will speak on behalf of all of us here in Vermont who are engaged in this work, that we really look forward to your robust communication plan, because I think you've given us a lot to think about on today's webinar, and also just, there's clearly a lot to do, and, it's only by doing it all together and working together that we can really figure some of this stuff out. I want to thank everyone who participated for attending today's webinar. the opportunities to improve models of care for people with complex needs, and a special thank you to Caitlin Thomas-Henkel from CHCS for presenting on this topic. Once you leave today's webinar, you'll receive a survey on the presentation, and we would appreciate if you would complete that and provide your feedback. You will also receive a follow-up email within 24 to 48 hours with a link to view a recording of today's webinar. And also, I think we have a little bit of follow-up from some of the questions that we'll be getting back out to you all who participated. So thank you, Caitlin, for the follow-up there. And on behalf of the Vermont Healthcare Innovation Project, we want to thank you for joining us today and hope you enjoy the rest of this lovely Wednesday afternoon. Thank you.